Good evening, everyone. I am Prashant Agrawal. On the behalf of Adley Oncology, I would like to welcome Dr. Amit Khurana, eminent speaker, Dr. Anita D'Souza, a panelist, and the participants. I will take only 1 minute to brief about the company. Adley Oncology is dedicated to oncology and among few Indian oncology company working on new drug delivery system. Our robust infrastructure, highly experienced management team, strong financial performance, and the backward integration made us the market leader in cytotoxic market. We always try to work to make or improve the patient's life better. That's why we are continuously working on new drug delivery system, working on NIPS, working on the PARP inhibitors. We have recently launched the Adstrom, that is Eltrembopag, and that is the reason we are having the rich portfolio in hematology basket, comprises of the carfimib, carfilzomib, bidan, dasatinib, Adstem, MDSO, Pag-Elasgen, so on. Not only the hematology basket, but we are having the very rich portfolio in the solid tumor basket also. Very soon, we are coming up with nilotinib. In this month only, we will launch nilotinib. The brand name is the Kylonib. Not only this, with the approval of the PICS, now we are expanding ourselves in more than 40 countries. And at the end, I would like to thank all the doctors for their patronage towards Adley Oncology. Thank you very much.
Thank you, Mr. Prashant.
Now, yeah. Thank you, sir. Thank you. I hand over the things to you, sir.
Thank you, Mr. Prashant. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Anita D'Souza from Milwaukee, USA, and she's going to lecture us on AL amyloidosis, a difficult disease to treat. This webinar is brought to you by Mumbai Hematology Group, supported by Adley Oncology, and managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team Adley, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Anita D'Souza from USA. All our discussants were themselves eminent hematologists and medical oncologists, and you participants for sparing the Saturday evening, morning, and afternoon. Tomorrow, that is 17th of September 2023, Sunday, from 11:30 a.m. IST onwards, we have a webinar on challenges and opportunities in the management of pediatric acute myeloid leukemia by our own guest speaker, Dr. Chetan Tamne from Tata Memorial Hospital, Mumbai. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Ashish Dixit from Comprehensive Cancer Center, Manipal Hospital, Bengaluru. Dr. Cecil Rose from St. John's Medical College Hospital, Bengaluru. Dr. Divya Manohar from Madras Medical College, Chennai. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. K. Govind Babu from HCG Hospitals, Bengaluru. Dr. K. S. Natraj from Sri Shankara Cancer Hospital and Research Center, Sankarapuram, Bengaluru. Dr. Krishna Rathanam Kannan from Sri Ramchandra Medical Center and Sundaram Medical Foundation, Chennai. Dr. Leo Prince Mathan from Rela Institute, Chennai. Dr. Mahesh Rajashekara Rai from Sparsh Hospital, Chennai, Bangalore. Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bengaluru. Dr. R. Prasanna from Cure Cancer Center, Tamil Nadu. Dr. Sanjukta Rao from St. John's Medical College, Bengaluru. Dr. Satish Kumar from Manipal Hospital, Yashwantpur, Bengaluru. Dr. Shilpa Prabhu from Mazumdar Show Medical Center, Bengaluru. Dr. Shrikant Murali Krishnan from Apollo Hospitals, Chennai. Dr. Tejaswini Gudibande from Narayan Health Mazumdar Show Medical Center, Bengaluru. and Dr. Thila Gavati Venkatesan from Prashant Multispecialty Hospitals, Chennai. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Anita D'Souza from Milwaukee, USA. Dr. Anita D'Souza is Associate Professor at Cancer Center, Froedtert Hospital at Medical College of Wisconsin, Milwaukee, USA. She is a distinguished physician in the field of hematology oncology and transplants and cell therapy, currently serving as the chair of the Plasma Cell Disorders Group at the Froedtert and Medical College of Wisconsin Cancer Center in Milwaukee, Wisconsin. She completed her MBBS and MD training at Goa Medical College in India and subsequently did her hematology oncology fellowship at the Mayo Clinic, Minnesota. She is an expert in the management of plasma cell disorders with a particular focus on light chain AL amyloidosis. She is actively engaged in research, leading an NIH-funded program aimed at developing pathways for the early diagnosis of AL amyloidosis and investigating patient-reported outcomes and health-related quality of life. In addition, she is a principal investigator on clinical trials exploring innovative therapies for patients with AL amyloidosis and multiple myeloma. Today, she is going to lecture us on AL amyloidosis, a difficult disease to treat. Well, thank you so much. Over to you, Dr. Anita D'Souza.
Thank you, Dr. Khurana. Let me start sharing my screen. Do you all see it in the right mode?
Absolutely, yes. Please go ahead.
All right. Excellent. I want to start by thanking the Mumbai Hematology Group for inviting me to give this talk. I'll start with a personal story. When I finished my MD in Goa, I really wanted to pursue hematology as a career, but I didn't know what a hematologist, what kind of practice and what kind of life people led. So I remember attending a Mumbai Hematology conference in Mumbai at that time, in person, and I was just so inspired spending time listening to all the talks. And after that conference, I wrote to Dr. Maman Chandy at CMC Vellore, and he invited me to come and spend some time there. And I spent 6 amazing months doing hematology in Vellore. And I think that's where it all started, my love for hematology. So I think like this is a great opportunity for me. It feels like I've come full circle. And once again, I thank you for inviting me to do this talk today. I removed the part a difficult disease to treat because I'm hoping that when we finish today, you won't feel that it is that difficult a disease to treat. These are my financial disclosures, many of which are from clinical trial support that comes to the institution, pharmaceutical funded clinical trials. So the objectives of today's talk, I want to start with just some basic AL amyloidosis epidemiology, how we stage the disease, how we assess response, progression in this disease. And then we will spend the bulk of time talking about treatment for newly diagnosed and relapsed refractory AL. And we'll end by touching base on supportive care of patients with AL amyloidosis. So let's start with a patient case. You're evaluating a 74-year-old male who was recently seen by his internist for increasing shortness of breath. Echocardiogram showed evidence of infiltrative heart disease with thickened interventricular septum and diastolic dysfunction. The SPEP that you ordered came back showing an IgG kappa monoclonal protein of 1.2 gram per deciliter. You ordered a fat aspirate, and the pathologist reported the presence of amyloid demonstrated by positive Congo red stain. The bone marrow biopsy shows less than 10% clonal plasma cells. They are kappa restricted, and there's no amyloid in the bone marrow. So in your clinical practice, what would your next step be? 1, would you continue with supportive care alone, managing the heart failure symptoms? 2, would you do an endomyocardial biopsy as a next step? Remember that the patient has a diagnosis of amyloid on the fat aspirate. 3, would you request subtyping of the amyloid deposit in the fat aspirate specimen? And you can pick whichever subtyping method you have access to. Here I've put as mass spec analysis, but this might be immunohistochemistry or other subtyping methods? 4, would you start treatment with Cybol-D or bortezomib cyclophosphamide dexamethasone chemotherapy? Or 5, would you start treatment with Dara-Cybol-D or adding daratumumab to the Cybol-D regimen? I don't know if you're able to add into the chat function, but that's okay. I want you all to think through the options, and I hope some of you have picked option number 3, which is subtyping, which is the correct answer. So in this case, you really don't know what kind of amyloidosis this patient has. It's an older male. These patients are also at risk for age-related transthyretin amyloidosis. And in prior studies, people have shown that if you look at cardiac biopsy proven TTR amyloidosis, 25% of these patients have an MGUS. And so given that older age group male patient population, these patients are also at risk for having MGUS. And so without knowing what subtype it is it ATTR or AL, making the assumption that this needs to be treated with chemotherapy is incorrect. You don't need to do an endomyocardial biopsy because you already know that this patient has amyloidosis. And no, we wouldn't want to continue. While supportive care is an important part of management, here we know the patient has an underlying disease that's driving the heart failure. And so you doing supportive care alone would be incomplete. So in the right clinical setting, it is really important to suspect the diagnosis of amyloidosis. If you don't think of this disease, you won't make the diagnosis. And after suspecting the disease, the diagnosis, the next important step is confirming with tissue diagnosis that this is amyloidosis. And then furthermore, doing subtyping to determine what subtype it is. There are about 42 different types of proteins and peptides that can misfold into amyloid material. All of them look the same under the light microscopy as Congo red positive or whatever stain you have used, amyloid deposits. The only way of knowing what subtype it is by doing additional testing with immunohistochemistry or mass spectrometric subtyping. So what is the clinical setting in which you should think of amyloidosis? So this is data which comes from patients, so patient-reported data, patient interviews, and as well as responses from surveys. And what patients tell us is that many of them had symptoms for many months to sometimes years before the diagnosis of amyloidosis was made. And the most prevalent symptoms that patients describe are fatigue, dyspnea, fluid retention, swelling in their legs. They often have dizziness on standing, this orthostatic hypotension coming from autonomic neuropathy of amyloidosis. Sometimes they describe this fullness in the stomach, again, a subtle feature of autonomic neuropathy. They might have GI symptoms, constipation alternating with diarrhea, peripheral neuropathy symptoms. Weight loss is common. Sometimes that gets masked because of the fluid retention. Now, purpura and enlarged tongue, while they are more pathognomonic of amyloidosis, this macroglossia, where patients have this lateral scalloping of their tongue from impressions from the teeth and the palate, and bilateral periorbital purpura, these are very diagnostic. When you see that, you think of amyloid, but these are very uncommon. Only about 20% of patients or so have these soft tissue patterns of presentation. And for all of these other non-specific symptoms, I think the suspicion should be heightened when they coexist rather than just having one symptom. And in a patient in whom we suspect amyloidosis, it's very important to screen for the monoclonal process. And I think of the monoclonal process, the complete assessment, as requiring a serum protein electrophoresis, the SPEP, along with the serum immunofixation electrophoresis, along with a urine protein electrophoresis with immunofixation. And that has to be done along with a free light chain assay. So if you do these 3 sets of tests, it has over 99% sensitivity for picking up amyloidosis. The problem is that it's not very specific. So you'll have patients who have a small monoclonal protein, but turn out not to be amyloidosis. But once again, to reiterate, you have to do all those tests, the serum, urine, and the free light chain to screen for the monoclonal process. The next step is if you find that the patient has a monoclonal protein, is demonstrating the tissue deposition of amyloid. And this is where you have to do a biopsy. And after finding amyloid, again, confirming the protein of origin, so subtyping of that amyloid deposit. So how do we do, where do we look for amyloid? So some of the common sites are fat aspirate because that's easy to obtain, but fat aspirate has on its own has about 50% sensitivity for detecting amyloid. When combined with a bone marrow biopsy, that goes up to around 85 to 90%. Salivary gland biopsy is also helpful. Minor salivary glands or even the major salivary glands, they often have amyloid deposition. The GI tract, I've done some gum, sometimes tongue biopsy. I've stopped doing rectal biopsies, but that's another common place where amyloid is often detected. And if you don't find amyloid in this easily accessible tissue, it is very important not to stop there, go straight for the target organ. So if you think the patient has renal amyloidosis, doing a kidney biopsy or an endomyocardial biopsy in the setting of suspected cardiac amyloidosis. The staining that is required is the Congo red stain with that characteristic apple green birefringence on polarizing light microscope. Other stains like thioflavin T or S can also be helpful to detect amyloid. And to determine the subtype of amyloid, there's immunohistochemistry. This has to be done in the hands of experienced pathologists. The stains can be very finicky. And so in the last 15 to 20 years, in the US, we have started using mass spectrometry based on data that was generated from the Mayo Clinic. And most of my patients, when we find amyloid on a tissue biopsy, we send it to Mayo to get the mass spec subtyping done. There are other very sensitive methods like immune electron microscopy, but I don't have access to that. They're done at very specialized handful of centers in the world. What are the blood tests that you should think of doing in terms of working up for organ amyloidosis? So for the heart, the blood tests that are very important are the cardiac biomarkers. And this is the BNP or NT-proBNP along with troponin, either troponin I or troponin T. The EKG can be very helpful to look for amyloidosis. Characteristically, these patients have a pseudo-infarct pattern, or you may see low voltages in patients with advanced infiltrative heart disease. Arrhythmias are common in these patients, and you may pick that up on an EKG as well. The echocardiogram has a number of findings that you'll see because of that infiltration in the heart muscle. Increased septal thickness is very common. Diastolic dysfunction and sparing of the ejection fraction. So these patients have grade 2, grade 3 diastolic dysfunction. Their EF is normal. So this characteristic heart failure with preserved ejection fraction picture. And echo should ideally be done with the strain pattern and to look at global longitudinal strain. And these patients have this characteristic apical sparing, what is called as the cherry on top appearance. A heart MRI, if you have access to that, especially when it's done with contrast, with gadolinium contrast, shows the delayed gadolinium enhancement, which is a hallmark of cardiac amyloidosis. Patients can also have, when you do it with contrast, you can measure extracellular volume or ECV, and that has prognostic implications, but also can show change, response to treatment. So as patients get better, that ECV starts improving. Other tests like the technetium 99 scan or the old bone scan, so the scintigraphic imaging studies Like DPD scan is another one that's available outside the US. These are more specific for TTR amyloidosis. Now, about a third of AL patients who have heart involvement do have some uptake on these scans. But in a patient where you think of heart amyloidosis, if their technetium 99 scan shows no heart uptake, that in that particular patient, I'm even more, my suspicion for AL is much more high. Other organs for kidneys, we look at a 24-hour urine protein or a urine albumin creatinine ratio. Elevated creatinine reduction in EGFR tends to be less common at diagnosis because these patients predominantly renal amyloid presents as nephrotic syndrome. For hepatic amyloid, we are looking at enlarged liver on exam or on imaging studies and elevated alkaline phosphatase, uncommonly elevated bilirubin. When I see a high bilirubin, that's usually a bad prognostic sign. And the rest of the organs, they are very hard to detect. It's usually by biopsy or by symptoms that I go by. We don't have really good tests. And the one additional uncommon thing is some of these patients can have an acquired coagulopathy due to an acquired factor 10 deficiency. And so these patients tend to have more of a bleeding phenotype. And usually when there is an acquired factor 10 deficiency in amyloidosis, that's a sign of more advanced disease, usually improves with treatment. What are the patterns of organ involvement? These are data from the Mayo Clinic, and about 75% of patients have one or two organs involved. I think this is also a matter of how quickly or how delayed the diagnosis happens. In patients with very delayed diagnosis, I think they have more organ involvement. So this multi-organ, 3 or more organs involved. These patients tend to be usually in more advanced stage at diagnosis. The heart is the most commonly involved organ. In 70 to 80% of patients, the heart is involved, followed by the kidneys, which is about 50 to 60% of patients. After that, it's nerve, followed by liver, followed by GI. Those tend to be between 20 to 30%. So again, to reiterate, after diagnosing a patient with AL, our job should not stop there. It is, we need to subtype so we know exactly what we are going to treat. And then the next step then is risk stratification, knowing which organs are affected and following that, which biomarkers to follow in these patients as you start treatment. In an oversimplified slide, this is the pathophysiology of amyloidosis. It starts in the bone marrow, and I'm talking about systemic AL amyloidosis. There's also a localized AL amyloidosis, and if we have time, we can discuss this at localized AL at the end. But in systemic AL amyloidosis, the bone marrow plasma cell clone is where clonal free light chains are made, which then misfold into insoluble fibrils that deposit in organs and lead to organ dysfunction. All our treatments, we gear to this part of the problem, which is using plasma cell-directed chemotherapy. And we have a few of these treatments, stem cell transplant, all of which are effective. But keep in mind that plasma cell-directed chemotherapy has no direct effect on misfolded amyloid fibrils or organ deposition. And for this part of the problem, which is what patients feel sick from, we really don't have effective treatments. What we have are these, which once they start working and you stop producing new free light chains and stop making more amyloid, slowly organ amyloid improves. So this needs time. But in that initial phase of treatment, chemotherapy adverse effects can worsen organ amyloid by causing fluid retention, cardiotoxicity, and neuropathy. So how do we stage patients? So there are a few staging systems. I'll focus on cardiac and renal staging here. And the first staging system was developed by Dr. Angela Dispenzieri from the Mayo Clinic in 2004. And she used just 2 biomarkers, very simple staging, using an NT-proBNP and troponin value. And if patients had neither of these markers above the cutoff, then patient had stage 1. One marker above the cutoff, then stage 2, And if both markers above the cutoff, then stage 3. In 2015, there was a modification of this staging system to divide stage 3 into 3A and 3B based on how high the NT-proBNP was above 332, with that threshold being 8,500. Patients whose NT-proBNP was greater than or equal to 8,500 were called as Mayo stage 3B staging. In 2012, the Mayo Clinic revised that staging system by taking into account the free light chain burden. And this is derived as difference between the involved and uninvolved free light chain. So if a patient has AL lambda, you would calculate DFLC as lambda minus kappa. And here we use a threshold of 180 milligram per liter or 18 milligram per deciliter, depending on how you get your labs in which units. And then note that the thresholds for NT-proBNP and troponin slightly changed. So here we are using 1800 and 0.025 as the cutoffs. And now with 3 markers, you can divide patients into 4 stages based on, again, how many markers are above the cutoff. And you can see that patients with stage 1 amyloid have actually pretty decent outcomes looking at 5-year survival from the time of diagnosis. Even stage 2 have decent outcomes, but not as good as those patients who have none of these 3 markers. But the moment a cardiac biomarker is involved, you start seeing this rapid decline in the first 6 to 12 months after diagnosis. And those are the patients that typically present in heart failure or have a lot of heart symptoms. And those are the patients where none of our chemotherapy treatments thus far have made a huge jump in improving outcomes, because again, our treatments don't work directly on amyloid deposition, and that part takes time. And some of these patients who have advanced disease, advanced heart involvement, just don't have that time to respond to have their hearts get better after starting treatment. There is a renal staging system developed in Pavia in 2014 by Dr. Palladini. And here the EGFR and 24-hour urine protein is taken into account. And once again, the staging is very straightforward based on whether these cutoffs are met or not. And patients with stage 3 renal staging, they have a higher risk for end-stage renal disease after starting treatment. So it's something that helps us prognosticate, plan, and work closely with our nephrologist, thinking ahead that this patient may likely need to go on dialysis, or further down that this is a patient you may want to consider for kidney transplant. So what are our goals for treatment with a newly diagnosed AL patient? Our main goal is a rapid and deep hematologic response. And here we are focusing on that involved free light chain. How quickly can we normalize or near normalize the free light chain? Then we want that response to be durable, but both of these have to be kept. What you have to keep in mind is these patients are frail. We have to minimize toxicity. So using a risk-adapted approach that does not further decompensate patients, and then good supportive care. Now, how do we measure response in patients? The hematologic response is all with the free light chain, the DFLC. We also look at the SPEP and UPEP to, if patients have an M protein, how much has that reduced? Has it gone away completely? For organ response, this becomes more tricky. Cardiac response with biomarkers, we use the NT-proBNP. For renal, it's the 24-hour urine protein. We want to make sure that patients are not losing renal function, and we assess that with the EGFR. And for the liver, it's with alkaline phosphatase. With imaging, now these are becoming more important with fibril-directed therapies, and even in ATTR and other amyloid subtypes, can we, with newer and novel therapies, can we quickly detect if the heart is improving? And these imaging studies are currently being studied further. The global longitudinal strain on an echo, ECV tracking on a cardiac MRI are both very promising early imaging modalities that are being looked at. And then I am very interested in functional outcomes, because I think that's one way of that patients can tell us if they feel better after starting treatment, or if things are getting worse. And there are some domains of quality of life that immediately show that change even within the first year after diagnosis. And we can look at those patient-reported outcomes with various validated quality of life instruments. There's also other functional tests, such as the 6-minute walk test and the NYHA functional heart failure class. What are the definitions for response criteria? So here our amyloid hematologic response criteria differ a little bit from myeloma response criteria. The CR part is very similar to myeloma, except we don't need a bone marrow biopsy to show change, reduction in plasma cells. But for VGPR, what we are really looking at is how much have we improved the DFLC? Has it come below 4 milligram per deciliter or 40 milligram per liter? If DFLC decreases more than 50% compared to baseline, but not at VGPR rate, those patients are called as PR, and then all other patients are no response. There's also a form of amyloid with low DFLC at diagnosis, and those patients have slightly different criteria where we don't have VGPR, because at start, their DFLC is already below 40. And so there we are looking at CR, PR, or no response. For organ response, similarly, we have the NT-proBNP, the NYHA class. For both response and progression, there are different thresholds, and it's hard. It's a very dry topic to keep these different cutoffs in mind. And even I sometimes forget this, and I just have printouts in my clinic that I just follow when I'm seeing patients at 100 days after transplant or 1 year after transplant to see which bucket they're falling in. And you're constantly using a calculator to see how much the NT-proBNP has reduced compared to where it was previously or at baseline. And another challenge is that we have different biomarkers. So there's NT-proBNP versus BNP, and the cutoffs are a little different. And similarly, if you do the old troponin T versus the new high sensitivity or 5th generation troponin T, that the threshold, the units are a little bit different. So this is another handy table that I often use to cross compare depending on where patients have had their labs. So let's do now one more patient case. Now we go into treatment. So you have a 61-year-old man with fatigue, edema, dyspnea, and bruising around the eyes. Vital signs are listed there. Labs show lambda of 32 milligram per deciliter, kappa is 0.8. You can calculate the DFLC. NT-proBNP is over 5,000, 0.07, EGFR of 48, 24-hour urine of 4.8. Bone marrow shows 7% lambda cells, translocation 1114 positive, Congo red positive. Mass spec typing is done, and this shows AL lambda deposits. Echocardiogram is listed there, thickened interventricular septum, normal ejection fraction with an abnormal global longitudinal strain. And the PET scan is negative for lytic lesions. So in this patient, based on the most current evidence, now I understand that this may not be what you may practice, but based on most current evidence that is out there, what would the most appropriate treatment in this patient be? Would it be autologous stem cell transplant? A clinical trial is never a bad idea, but a clinical trial involving just an antifibril therapy, daratumumab with Cybor-D, daratumumab with RVD, that's lenalidomide, Velcade, and dexamethasone, or 5, oral melphalan with dexamethasone. And let me put the patient case once again. So this patient has, these are the cardiac biomarkers, renal stage, DFLC is all over here. So in this setting, my correct answer here is daratumumab with Cybor-D. Even though I'm a transplanter, I'm always biased toward doing transplants. In this patient with an NT-proBNP of more than 5,000 and a troponin T of more than 0.06, we know that day 100 mortality after autologous stem cell transplant is just too high to take that chance with a patient like this. You wouldn't want to take a clinical, put this patient on a trial with just antifibril therapy, because that's only half the problem. You have to rapidly lower their free light chains. And then among the treatment options, you know, we don't generally use lenalidomide in upfront therapy of AL amyloidosis, especially when the heart is involved at that degree because of side effects. And oral melphalan dexamethasone, while there is a randomized clinical trial data from years ago that showed improved outcomes even when compared to transplant, you know, we have much better treatments now. And so let's review the data for dara-cyborg. So this was the Andromeda clinical trial, a randomized phase 3 trial that was published in the New England Journal of Medicine a couple of years ago. And this trial compared patients receiving VCD or Cyborg-D versus daratumumab with Cyborg-D for newly diagnosed AL. And in a safety run-in of 28 patients, 96% overall response rate, along with CRs of more than 54% was seen, and the treatment was well tolerated. There were no late toxicities. So 388 patients were then randomized 1-to-1 to get 6 cycles of Cyborg-D or 6 cycles of dara-Cyborg-D. The patients that got dara-Cyborg-D then went on to get 18 months of daratumumab maintenance. Patients were stratified based on Mayo stage. Now note that stage 3B patients were not eligible for Andromeda study, and there were other stratification measures as well. This study enrolled at over 100 sites in many countries in a very rapid way. It was amazing to see how quickly the study enrolled. And these were the endpoints. So one thing I want to point out, everything was very standard for these types of trials, but except for this major organ dysfunction PFS, which was a new endpoint that was designed and defined just in this trial. And this was our usual PFS definition, death or heme progression, but with the addition of organ death, so to speak, or severe organ dysfunction. So either requiring heart or kidney transplant or requiring end-stage organ transplant support. So what was seen for primary endpoint was a complete hematologic response of 53% versus 18.1% for Cyborg-D. And comparing outcomes of patients, you can see that heme progression and treatment change favored very much dara-Cyborg-D versus Cyborg-D. However, any deaths or deaths particularly by day 60, so early mortality, was not any different. The MOD PFS, this is what the curves looked like, again, very much in favor of dara-Cyborg-D. In terms of key organ status, and these reports that we have so far are early outcomes, because what was reported in the New England Journal paper were just at a median follow-up of 11 to 12 months. So we have organ status at 6 months, which showed a cardiac response of 44% for dara-Cyborg-D versus 22% for Cyborg-D. And for renal, it was 53 versus 24. So what it looked like is at 6 months, cardiac and renal response rates doubled and organ progression reduced by approximately 2/3. So based on these data, dara-Cyborg-D became the first approved therapy, the first in the US, the first FDA-approved treatment for AL amyloidosis, and became the new standard of care for all newly diagnosed AL amyloidosis patients. So even though we have 19 FDA-approved treatments in multiple myeloma, this is the only one that is approved in AL amyloidosis. So what we learned a lot of things from this trial, but then there are still a lot of unanswered questions. So what we learned is adding daratumumab to Cyborg-D improved the complete hematologic response rate and doubled cardiac and renal responses at 6 months. However, daratumumab did not improve early cardiac mortality. And keep in mind that this study did not include stage 3B patients. So even in patients with less advanced disease, we did not see an improvement in early mortality. What we did not learn, we have absolutely now no idea where do we place transplant in patients who are transplant eligible, the ones who meet eligibility criteria based on their biomarkers and functional status. Do we transplant them? Do we not transplant them? We don't know in patients who achieve a complete hematologic response at 6 months, do we continue them on DARA maintenance to complete 2 years of treatment? We don't know that long-term survival will be improved with addition of daratumumab. And then finally, because this study did not include 3B patients, we don't know the safety of daratumumab in patients with advanced cardiac stage. Now that last point, there are now single center studies, there are some early smaller clinical trials that have shown that it is safe to use it and may actually improve outcomes and reduce mortality in patients with 3B disease. But I think the question of transplant is very valid. What if you don't have access to daratumumab in upfront therapy? I would still very much favor using transplant in those patients, but keeping in mind that transplant eligible patients in all comers with newly diagnosed AL amyloidosis, it tends to be around 20 to 25% of patients. So it's certainly a very selected and a small subset of patients. Other than daratumumab, what are the other monoclonal antibodies in AL amyloidosis? There's isatuximab, which is also a CD38 directed antibody. And then there is elotuzumab, the anti-SLAMF7 antibody that is also approved in multiple myeloma. Now, I have to say anecdotally, I don't like using elotuzumab after DARA because we have seen that the responses tend to be blunted. But if you have a patient who has had daratumumab long time ago or has not had exposure, I think elotuzumab is a much better tolerated treatment and has efficacy as well. There are some interesting and exciting monoclonal antibodies targeting the other half of that slide I'd shown a while ago. So we have now monoclonal antibodies that have been designed to remove these oligomers and tissue amyloid from tissues. So one of them is anselamimab, or also called as KL101, and the other is bertamimab, or NEOD-001. These drugs have been tested in early phase trials, but we don't have full evidence that they work. And currently there are a number of phase 3 studies that are ongoing that are trying to determine in newly diagnosed patients with advanced heart involvement, does use of these drugs along with standard of care chemotherapy help protect these patients from that high early mortality in the first 6 to 12 months. So these trials are ongoing. I think in the next 1 to 2 years, we will know more about their efficacy. Now, when to move to second line therapy? And I look at this as, one, if we have issues with toxicity from the drugs we are using. Two, very important to consider that sometimes the induction regimen patient might be refractory or have an inadequate response. We have to be very vigilant to changing treatment early. And third is in patients who have had good response to upfront therapy, but now are relapsing or having progressive disease. So what is considered an inadequate hematologic response? So these data come from the UK National Amyloidosis Center. And in patients with newly diagnosed AL, there are 2 risk factors to consider. One is if the baseline DFLC is more than 40 milligram per deciliter or 400 milligram per liter, and if they achieve less than a PR at 1 month. So if they have both of these risk factors, the likelihood of achieving improved response by 6 months is very low. So our recommendation is at 1 month, if they're less than PR, change therapy in these patients. Now, the other 2 groups, if they don't achieve a VGPR by 3 months, those patients have only 23% of those patients had improved response at 6 months. So for those patients who have one or none of the risk factors, wait until 3 months, and change therapy if they have not achieved a VGPR by 3 months. How do we define hematologic relapse or progression? So we have criteria that kind of mirror our IMWG criteria for myeloma. But again, we are paying closer attention to that involved free light chain, the DFLC. And then a few years ago, the Pavia group put out this definition of high-risk DFLC progression, which takes into account what was the baseline DFLC, how low did it go at best response, and where it is in relation to those thresholds at the current time when you're suspecting relapse. And I find that a very useful tool to determining, because that number could be different for different patients. So you can take, it kind of is personalized for a given patient. So what are some of the other drugs we can use in this setting? I think that we have options, but we have to keep in mind that this is not just like pulling a myeloma drug and using it in amyloid patient. These patients tend to be frail. They tend to have more toxicities to chemotherapy drugs. And so for every drug class we have, I'm worried about the kind of side effects I would expect to see. And sometimes this depends on what is the organ that is involved in a given patient. So for example, if the patient has severe heart involvement, I would be very scared to use a drug like carfilzomib, which we know in amyloidosis can have even greater cardiotoxicity and fluid overload. IMiDs, there is a class effect with immunomodulatory drugs in amyloid that it increases biomarkers, but patients don't have worsening and heart failure necessarily. So even though we don't use IMiDs upfront, I'm actually okay using them in the relapse setting. And we actually have a clinical trial currently open at our center where we are combining an IMiD with daratumumab, and we have seen patients tolerate this okay, as with careful watch for side effects, and have deepening in their responses compared to how they responded when they had daratumumab in the past. I think there are some interesting new data coming out for BCMA-directed treatments in this setting, but keep in mind that the risk of CRS with drugs like teclistamab, even with CAR-T, there are case reports and small studies that have shown that CAR-T is associated with very high response rates in amyloid patients. But I worry about toxicity, especially in patients who have advanced and multi-organ involvement. I want to spend one slide talking about BCL2 inhibitor, venetoclax. So 40 to 50% of amyloid patients have translocation 11-14. We know that venetoclax, when used in myeloma, the group in whom we see good responses are patients with translocation 11-14. And similarly in amyloid, we have seen really good responses using even smaller doses, single therapy of venetoclax, and tends to be quite well tolerated. And these are some retrospective series that have shown really deep responses, durable responses. So this has become my first relapse drug of choice in amyloid patients who have translocation 11-14. And we have a clinical trial that will start where we will test this in the setting of a prospective study. I think supportive care is very important for patients. Antivirals, anti-nausea medications, acid blockers, sleep aids, diuretics, laxatives. I always think of those when we are starting treatment patients on CyBorD-based regimens. I think some of the other supportive care things to keep in mind for cardiac and renal, it's usually diuretics that are the mainstay. Remember to avoid heart failure, typical heart failure drugs. Beta blockers are not well tolerated at all in amyloid patients. A lot of times I'm stopping beta blockers in my patients that have been started on those by cardiology or their primary care doctor. With atrial fibrillation, digoxin can have more toxicity, but if you're aware of it and watchful, keeping their electrolytes under good control and watching for dig levels, you can use it safely, but there's a risk that digoxin gets adsorbed on amyloid fibrils and can lead to prolonged dig toxicity. For neuropathy, that can be a difficult to treat the symptoms for, and patients tend to have really impaired quality of life due to bad neuropathy. And really, you try to choose whatever you think your patient can tolerate. Some of these medications can have more side effects. I'm trying to use topicals or TENS, even acupuncture. I think PTOT is important in these patients to try and maintain their function. And autonomic neuropathy, which is another difficult symptom to treat, is usually we are using drugs like midodrine or droxidopa in patients to maintain their blood pressure. So in conclusion, the take-home points, this is a heterogeneous disease with very protean manifestations. You need to suspect the disease. If you don't think of it, you won't make the diagnosis. Then rapidly confirming the diagnosis using appropriate staging and biomarkers to measure response to treatment. I think early treatment goal is getting patients into a rapid and deep hematologic response. If you have access to clinical trials with fibril-directed agents, those are good ones to consider. Currently, DARA-VCD being the only approved treatment is the standard of care for newly diagnosed AL. But I think this brings into question what is the role of transplant in AL amyloidosis, and I would love to have that discussion when we finish this talk. And there are multiple heme treatments that are available for relapsed patients, but knowing when to start treatment and watching for unique toxicities of various treatments is very important. And supportive care is extremely essential. I think of it as treating with chemotherapy is only half the job. So this is a very essential part of management of AL amyloidosis. And with that, I'm sorry for going beyond my time, but I want to end by acknowledging my group here at MCW. And I've put my email there. If anyone has further questions, feel free to email me even after today's discussion. Thank you.
Thank you, Dr. Anita D'Souza, for that wonderful talk. It was awesome, fantastic, superb. So now I request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Anita. So the first is Dr. Krishna Rathanam Kannan. Sir, please, your question, please.
Thank you very much, Anita, for an excellent overview of amyloidosis. As rightly mentioned by, the chairperson, the key talk, the question will be on transplant. So can you please highlight who are the, especially after this DARA has come into the scene, it has become a little bit confusing whom to offer transplant. So can you please highlight which patients do you offer transplant? Who are the transplant eligible patients? And what scenario you use? What are the various scenarios you use transplant? Can it be used when there is a PR or relapse? And in upfront, what are the indications and what are the contraindications?
Yeah, that is a great question to start this discussion, because I face this challenge on a weekly basis in clinic. The patients I used to take to transplant before, now many of them are in a complete hematologic response. And you know that even though transplants have become safer compared to the 2008 NEJM paper from France, Meldex versus transplant, which showed transplant had very high day 100 mortality. Now transplants, we are doing them much safely. We are selecting, we know who not to do transplant in, and so the patients we take to transplant have very good outcomes. But in a patient who is in a hematologic complete response, you don't know what is the additional value of doing a transplant. And so last year, the European Hematologic Association and the International Society of Amyloidosis, the EHA-ISA, put out guidelines that in patients who are in a complete hematologic response, you should just continue them on the Andromeda type regimen. But even in those patients, we really don't know what is the value of continuing DARA maintenance. So sometimes I have patients who don't want to come monthly to get daratumumab injections, and they choose to get a stem cell transplant so they can just come off all treatment and go back to living life. And so I kind of use that as at that 3 to 4 months. if patients, I will have that discussion. I will offer stem cell collection and give that option of either doing the transplant at 6 months or deferring it based on what is happening at 6 months. And I will have some patients choose to get a transplant and they want to come off data altogether. But I have to say, my personal practice, my transplant utilization has gone down more than 50%. And we have a clinical trial in the works done through the cooperative groups. ECOG, SWOG is the main lead, and we'll be doing it also through the Blood and Marrow Transplant Clinical Trials Network, where patients will be randomized after dara-CyBorD after 3 cycles to either get transplant or continue on dara-CyBorD. So maybe that trial will give us more answers in the future.
Can I ask one more question?
Sure, please go ahead, sir.
So now, I have a few patients, despite being in complete hematological response and biochemical response, their organ function, lags behind. And one particular patient, the renal failure has worsened despite being in complete biochemical and hematological response. Is it a common occurrence, or can it happen?
It happens. It's not common, but it's not uncommon either. One thing is that patients can take there can be a long lag time between hematologic response and organ response, but during that time, sometimes you see actually organ progression. And I think this is where the role of these new fibril-directed treatments has a place. Especially when they were done in the early phase trials, the patients that were enrolled on these studies were those that had finished their chemotherapy treatment, had achieved a heme response, and were waiting for organ response to happen. And so I think in those patients, particularly if we find that these fibril-directed therapies work, we would want to test, can they help the organs recover or bring them back from that progression back. But I think in my experience, the damage that has happened generally tends to be, you can't reverse it. It is halting the progression and stabilizing the organs from getting worse. That really is what I hope to achieve in clinic, because I never see, once they start progressing, I don't see that reverse often.
Have you ever offered renal transplant for patients with progressive renal failure?
Yeah, that's a really good question, and it's very dependent on where you practice. So in my center, my renal allografter, they want 3 to 5 years of complete hematologic response before they'll even consider the patient they'll even see the patient for renal transplant evaluation. So I have maybe 2 or 3 patients now that have had a kidney transplant. In other centers, like at Mayo, they have offered even after 6 to 12 months. And the idea here is, even if the disease relapses, you have option of all these different treatments. And so you would be able to treat them in a much deeper fashion if they had good renal function. So I think renal allograft, if it is available, is an option, but it's a highly selected group who actually is able to get the organ.
Thank you very much.
Thank you, sir. Dr. Cecil Rose, your question, please.
Yeah, I just wanted to know, Dr. Anita, now if mass spec is not freely accessible to most of us, so how often it is that you get ATTR compared to AL, and is it so necessary to actually rule out ATTR in an average cardiac amyloid?
So it can happen 1 out of 4 that you make a mistake. So it is too high to let it go to chance. So this is studies done from Mayo and even Boston University, where they looked at people who, because this ATTR happens to be more common in men and older men, right? And that's the same risk groups also for MGUS. So patients can have MGUS with coexistent cardiac TTR. And that's where, I think the mistakes can happen. Now, in a patient who has renal amyloid, on the other hand, and has a monoclonal gammopathy, I think there you're less likely to make a mistake, because ATTR generally doesn't go in the liver. But there are other rare subtypes like hereditary, a fibrinogen and other rare subtypes that can happen. So yes, like I think the odds are higher that it is AL, but the one that I worry about is in older men. Over here, it is African American men because they have a higher incidence of having an ATTR mutation. Those are the patients, and Black race is also associated with MGUS. So those are particular clinical scenarios where absolutely you need to confirm the subtype.
And you said that the immunohistochemistry, because that will be available for most of us, is a little finicky. What is the difficulty in doing immunohistochemistry? What is the problem? I mean, in the sense
so what happens with those reagents and the antigens have to be freshly made, and they have to be like the pathologist doing them has to feel comfortable that those work. And so in the right pathologist, like we have one in Loyola in Chicago, Dr. Pickens, who is like, if she tells me on IHC a subtype, I would believe that any day. But in our own center, like sometimes even our pathologist will tell, I think there is more lambda than kappa, but I'm not sure. So those are the situations. Then, there's no, like what I find is I wait for 7 days to get the IHC or wait for 10 days to get the mass spec report from Mayo, but I have more confidence in the report. But I think technical difficulty. The one setting in which I find IHC immunofluorescence is very good is in renal cases. I think the nephropathologists, generally immunofluorescence for subtyping works very well in kidney tissue.
Thank you.
Thank you, sir. We have some questions, ma'am, from the audience now. Dr. Nikhil wants to know that in patients who have got transplant eligible patients, when to consider for upfront transplant versus chemo followed by transplant?
Very good question. So if you're not going to use daratumumab based treatment and say you're having CyBOR-D, do you take patients directly to transplant or do you induce them for a few months and then take to transplant? So we did a large CIBMTR study a couple of years ago where we tried to look at that. And additionally, the question is, are there subgroups or subsets of patients where you should do that? So for example, if patients have more than 10% plasma cells. And what we found is induction was helpful to improve PFS, not overall survival, although our follow-up was very short. And it didn't matter what was the baseline plasma cell. So it had the same effect in patients with more than 10% as well as less than 10% plasma cells. And I think the other thing is practicality. When I have a newly diagnosed patient, it takes 2 to 3 months to get all the ducks in a row to get them to stem cell transplant. You have to get insurance approval, you have to get them on the stem cell collection schedule, and all of that some time to put in place. And I wouldn't want to not start treatment when we have drugs that work. And their risk in those first few months is very high if you don't bring down the light chain. So I think even practically speaking, it makes sense to get patients started on treatment. Now, there are some patients who have very, very small clonal burden and they have like a non-vital organ involvement where maybe there are scenarios where I would go straight for transplant. And I know there are centers that still go straight for transplant without induction. So I think it needs to be, you have to practice in the scope of where you're working, how that works out for you. But my practice has generally been to induce, then take to transplant.
Thank you, ma'am. And Dr. Sumit Milk has a question. Why do cardiac biomarkers increase in amyloid patients with IMIDs?
I don't know the answer to that. They do. I don't know why that happens. I think whether it's related to fluid overload, but I don't see their weight change. So it's a really good question. If you find out, you should let me know.
True. Another question he has is, in case of AL amyloid who has got renal amyloidosis as well as liver amyloidosis, treatment with DARA VCD is better. Treatment has been given with DARA VCD. Patient achieved complete hematologic response at 6 months, but stable disease for organ response. So should we continue for DARA VCD or to go for DARA maintenance?
Yeah, so organ response can lag behind hematologic response. So this patient could still have an organ response. We don't know whether to stop in these patients. So there are clinical trials that are currently being designed where we are giving options to patients to stop at 6 months or even at 1 year. But in the most available evidence that we have, we should continue daratumumab because that's the regimen. But we don't know the answer to that question.
Thank you. Another question from Dr. Hita B. In case of organ-limited amyloidosis of GI tract, stomach as well as small intestine presentation as upper GI bleed, no coronal plasma cell disorder has been shown. How to proceed with this case of amyloidosis of only GI tract without coronal plasma cell disorder?
Yeah.
Presenting
So this is
upper GI bleed.
Yeah, so this is a really good question. So this patient likely has localized GI amyloidosis. So treating with chemotherapy is not going to improve their outcomes. So here, the treatment is challenging because we don't have good drugs that can remove those deposits, and that mucosa is going to be friable, prone to bleeding. So good supportive care, making sure you keep their iron levels high. I have a patient who every 4 to 6 weeks needs a parenteral iron dosage and maintains hemoglobin. So you just try to do best supportive care in this setting. I also have patients, like I think GI amyloidosis is funny, and lung amyloid can also have that similar presentation where it can either be part of a systemic process or a localized process. And it's very important to differentiate between the two, because in the setting of a systemic process driving that organ deposition, you would use plasma cell directed treatment. But when you don't find a clone, like in this particular patient, there's no advantage, or there's no you're not going to make anything better. You'd only make things worse by giving chemotherapy.
True, ma'am. Another question from Dr. Bishwa Prakash. In a case of AL amyloidosis with renal as well as cardiac involvement, the anti-pro-BNP may be false. So in that case, what other cardiac biomarkers can be used for this risk stratification?
Yeah, there aren't additional cardiac biomarkers. Both troponin and NT-proBNP can get messed up in the setting of renal involvement. Even imaging can be hard. You have the echo with strain. Maybe you could use that, but you can't do an MRI generally with contrast in that setting. So you're basically there. That's where I think you going carefully by how patients feel is important, managing their heart failure symptoms, and using maybe patient-reported outcomes to determine response.
Thank you. Another question from Dr. Naresh Tayade. What symptoms are the main symptoms which will suggest you that, yes, this patient can have more likely to be amyloidosis?
Yeah, I think this is another tricky one, because many of the early symptoms are very non-specific. But I think, like, when you see them in combinations, that's where your suspicion should get higher. So like bilateral carpal tunnel syndrome in the setting of heart failure with preserved ejection fraction, that's a scenario I run into. And there is a study from Cleveland Clinic which showed that in that setting, there's like 10% likelihood of having amyloidosis. Now, if there are patients who have an alkaline phosphatase elevation, that's another, again, when it is combined with echo findings. So in patients with MGUS, there are data that you can use NT-proBNP, urine protein creatinine ratio, and alkaline phosphatase using different cutoffs, like 330 for NT-pro, urine protein creatinine ratio of 0.5, and elevated alk phos. When you see that, you should then investigate further for amyloidosis.
Right. Thank you, ma'am. Dr. Krishna, can you just be ready with your question? I just take one or two questions from the audience. I'll come back to you. So Dr. Naresh Tad has another question. If a patient has got genetic cause of amyloidosis, if there is any specific treatment available for this genetic cause of amyloidosis till now?
So it depends. That's a good question. It depends what is the mutation. Is this TTR amyloidosis? Is this, there are other hereditary types like A fibrinogen, APO. And so for hereditary ATTR, there are now some drugs that are approved in the setting of ATTR neuropathy. There is patisiran, inotersen, vutrisiran. So these, if you have access to these, but they only work if patient has TTR amyloidosis, not in other hereditary subtypes.
Thank you. Dr. Krishna Ratnam, your question, please. So,
And just a basic question, can you have a kappa AL amyloidosis?
Yes, you can. It is less common. So about 70%, 70 to 75% of AL patients have lambda subtype, but the remaining quarter patients have AL kappa.
Okay, so then one more basic question. When you have a serum-free light chain, what is the additional information you'll get by doing a urine immunofixation? Is it really necessary?
Yeah, I wish the IMWG and ISA removed the 24-hour urine from their systems, right? Like I don't like 24-hour urine. My patients don't like collecting it. It's cumbersome. But currently, that's the most reliable way to get the whole days. And when you just do a spot free light chain, there can be discrepancies, and that is why they have still not removed the 24-hour urine. It's still a requirement, but I completely hear you. It's a cumbersome test.
And just do you think in future the antifibrillary therapy and combination of plasma cell directed therapy will revolutionize the treatment of AL amyloidosis?
Yeah, I think that is the hope, but we also have to learn from history. So the NEOD 001 actually started its journey almost 10 years ago. So with bertamimab, we had early trials that showed similar promise, and then they did this vital study, which was a phase 3 trial. But in that study, it was newly diagnosed patients getting Cybor-D with Berta versus Cybor-D with placebo. And that study was stopped after interim analysis because it was found to be futile. And the drug completely went back a few steps. But then they did a subset analysis and found that patients who had advanced cardiac amyloidosis, and it's they had in vital, they had excluded patients with stage 3b, so people with more than 8500 NT-proBNP were not even eligible. But what they found is Mayo, the newer Mayo staging system, the ones with stage 4 amyloidosis, there was a improvement in survival, in quality of life, and multiple other endpoints in patients getting Berta compared to placebo. And so they went back to the FDA, and the FDA allowed them to do this focus study now in just with stage 4 patients. So I think it tells us that when we have tried doing it in other settings, these fibril directed therapies has not worked. And if there is a role, it is maybe in these patients with very advanced organ amyloidosis when they initially start treatment to try and lower their early mortality. But if they do show a benefit in that setting, I think we will all come back to the other scenarios that we discussed earlier, those patients who have achieved a heme response but still have organ disease or organ progression. Can we use them and try to get organs better? So I think like we have to wait for the data, but absolutely, I hope it they work, because we need these types of treatments. We have tried using other drugs like doxycycline. We did a trial here, and we found that using doxycycline, the 1-year mortality was low, and we had much higher transplant utilization in our series, but there was no difference. There was no organ response. And then there was a randomized clinical trial done in China that showed there was absolutely no difference in PFS, in survival with the addition of doxycycline to Cybor-D. So I think we come back to that similar problem that people working in Alzheimer's disease have. that it has been like the holy grail. How do you like developing drugs that can clear amyloid deposition? If that happens, it's going to absolutely revolutionize the field.
Thank you. Any other questions,
Thank
sir? Yes.
Just but the doxycycline, can we use the doxycycline when the organ dysfunction is not improving and just maintain with doxycycline?
There is no evidence to support it currently. I was a believer in doxycycline for a long time, and I used it in many patients. But following the recent phase 3 data, I've now stopped it. But again, more because I have access to these other fibril agents on trials. Now you could argue that in our phase there was lower 1-year mortality. So what is the risk? If you can do this safely, patients do have some toxicity. Photosensitivity is there with sun exposure. They can have GI side effects. We had in our series one patient who developed C. diff diarrhea. So those are the toxicities you may hit into, especially when you're giving antibiotics for such a long time. We know that's never a good thing to keep people on prolonged antibiotics.
Okay, thank you. Thank you very much.
Thank you, sir. Dr. Satish Kumar, just be ready with your question. In the meanwhile, I will take 2-3 questions from the audience. Dr. Nikhil wants to know what is the dose of venetoclax we use in AL amyloidosis with translocation 11-14?
Great question. I have gotten by with just using 400 milligram. I don't go for the full 800. I also don't use it in combination like we do in myeloma. I just give it as a single agent. So my response to that would be use the lowest dose that works. If you can get people responding at even 100 or 200 milligram, I would be open to using that.
Thank you. Another question from Dr. Heetha B. She has a case of amyloidosis of bone presenting as a recurrent fracture with bilateral hip replacement. Again, there is no clonal plasma cell disorder in the bone marrow study, and as well as the serum protein electrophoresis and immunofixation is absolutely normal. How to proceed with this case?
I think this is a good case where I would need to understand what is the subtype of amyloidosis. Are we assuming this is AL? Could it be some other subtype? I think that is a test that you should. I don't know if that has been done, but would be something I would need to know.
She has not mentioned it anything. Anyways, Dr. Satish Kumar, your question, please.
Yeah, thanks, Amit. Thank you, Dr. Anita, so much for that presentation. I have 2 to 3 questions. One is in your first case, what you presented, very typical. We get references from cardiology where the cardiac MRI or the technician scan is positive and highly suggestive of amyloidosis. And when we work up, because we don't have mass spectrometry, unfortunately. So the initial things, what we do, as you rightly said, serum protein electrophoresis, serum immunofixation, DFLC, FLC, and even urine electrophoresis and immunofixation. I also do a bone marrow aspirate and look for any clonality. And most of the times, everything comes negative. DFLC is normal, immunofixation normal, 24-hour electrophoresis is normal, bone marrow is normal, no increased plasma cells. And I even advise a fat aspirate or a punch biopsy, and that also comes negative for amyloidosis. So how do we proceed in such cases? Can we conclude that it is transthyretin or non-AL amyloid?
Yes, so in the setting of high uptake on a PYP scan with no evidence of a monoclonal protein on the studies, even you don't need to do a bone marrow in that setting or a fat aspirate. So that scenario, that algorithm has very high specificity for ATTR. So in that setting, you don't even need to prove that patient has ATTR. So as long as you have ruled out monoclonal gammopathy with your blood and urine tests, you can say that this patient, in the absence of monoclonal gammopathy, high uptake on PYP scan, this patient is ATTR.
Right. Thank you. The second question is, I have a patient, 69-year-old lady who has renal AL amyloidosis proven on renal biopsy, and NT-proBNP, everything is normal, echo is normal. First question is in renal AL amyloidosis, if the NT-proBNP, troponin T is normal, echo is normal, ECG is normal, should we go ahead with cardiac MRI and or technician scan to see if there is any evidence of cardiac amyloidosis? No need.
I wouldn't.
Right.
Yeah, I
So,
wouldn't.
yes.
Yeah.
So we went
Yeah.
ahead with Cybody. Her 24-hour urine protein was 17 grams. She was leaking 17 grams. After 6 cycles of Cybody, she's 69. They decided against transplant. 6 cycles of Cybody, the proteinuria came down to 3 grams. And her DFL, it was IgG kappa. She did not have any excessive of plasma cells. It was 5 to 6%. And yeah, the DFLC was around 52, not very high. It was kappa amyloidosis, but DFLC was 52. It came down to 16 after 6 cycles. So we stopped there and followed up. After 6 months, the 24-hour urine electrophoresis, the 24-hour urine protein jumped up from 3 grams to 6 grams. I repeated after 1 month, it came to 7 grams. And DFLC slowly creeped up from 16 to 31. So what do we do at this stage? She's absolutely
Yeah. Yeah, so this is a great case scenario because this patient has that low DFLC, even though it's just above 40 initially. And so in these patients, if you go by the strict, like the low DFLC criteria, this patient probably achieved a PR, not a CR, where the still had measurable protein by M spike. And so you could argue that with PR, she had a nice response to treatment. She had an organ response. But now as she's progressing, because you would call that progression if her 24-hour urine has jumped up, has doubled,
Right.
and is over a gram. So I would say, yes, she is progressing. So in this setting, I would consider deepening her response with some other treatment and seeing if that makes. But renal amyloid is another setting where it can take a long time for organ improvement to happen. Even after transplant, sometimes it takes good couple of years. But in this patient, it's not that she has delayed response. It is that she responded initially and now is progressing.
Right.
Would you
I think
agree?
Map would be a good drug,
Yeah.
but unfortunately they could not afford it. So
Okay.
given the options, I restarted bortezomib, but with lenalidomide and dexamethasone. Again, after 6 cycles, she's doing good. Her proteinuria has come down, but it's plateaued at 2.5 to 3 grams. DFLC has come down. So my next question is there any evidence of maintenance bortezomib in such patients? I'm really worried to stop it right now. I'm sure within few months, again, the proteinuria will increase. Any patients where you have given maintenance?
I have done maintenance, and these are the patients you learn from, what has happened in the past, or sometimes after even stem cell transplant, I might, if based on how bad their disease was, I might keep them for. But the problem with Velcade maintenance is the toxicity. So sometimes they develop neuropathy, and you have to be very careful with that, because given that neuropathy is also common with AL, you don't want to give them more toxicity from treatment.
Right. That's what was my worry, because she has developed some mild neuropathy, but it's manageable. That's what I've counseled them, that we'll keep her on bortezomib maintenance because the options are less. The other question, I think you partly answered. If the DFLC at diagnosis, you mentioned in your talk that wherever it's more than 40, it's easy. But if it's the initial DFLC is less than 40, it's only the organ response. I mean, I'm talking about renal AL amyloidosis. So it's only the organ response we need to follow up.
Yeah, and if there is any measurable DFLC that you can follow, like sometimes you'll even see patients where it's discordant. They have AL lambda, but the DFLC is more in favor of kappa. And so in those patients, you don't have anything measurable. Now, in these settings, I have sent MALDI-TOF mass spec based to see if I can find a small clone on mass spectrometry in the peripheral blood, because then you have something you can follow. But those cases are very challenging because you give chemotherapy, but then unless you have organ response, you don't know if it has worked or not. And organ response may not happen during chemo. It may lag beyond heme response.
Right. Thank you so much, Dr. Anita. Really appreciate it.
Yeah.
Thank you, Dr. Satish. Dr. Prisha, your question, please.
This is Dr. Mahesh. Sorry, it's in the name of my daughter.
Okay.
And yeah, so I have 2 questions for you. One, because our upfront option for at least 90% of our patients here would be Cybody, because most of our patients are not eligible for daratumumab because of the financial constraints. in such a case scenarios, do you we tend to take up for transplants, especially if the patients are quite young. So in those subset of patients, is there any necessity to give therapy to reduce the disease burden before you take up for transplant, or if it is okay to go upfront with a bone marrow transplant if the patient is ready to go for upfront autologous transplant without giving any kind of therapy to start?
Mhm.
Is there
Yeah,
any,
so this is,
unlike
yeah, this is
myelomas?
right. So this is something we had just discussed. We looked at this using the Center for International Blood and Marrow Transplant Research, the CIBMTR database, and we found that there was an advantage. There was improved PFS with using chemotherapy, both in patients with more than 10%, but also in patients with less than 10%. So this was my practice until 2 years ago. But I would start most of my patients with cyborg and then move to stem cell transplant.
And you are still looking for some kind of response before you take them up for transplant, at
Not
least a partial
necessarily.
response, or
Not necessarily. I think it's just to buy time till you get all your ducks in a row to get their stem cell transplant ready. But I
yeah.
wouldn't change if they have not responded. I'm looking at transplant as their next line of therapy in a way. But the people, most people on cyborg, like 60 to 70%, um, will have a good response. And in fact, even higher if you look at partial response. So the patients where you don't see a response with just cyborg are, I think, the translocation 11-14 patients, where there are data that bortezomib is not as effective for these patients. Now, fortunately, on Andromeda, there was a recent paper that looked at responses by cytogenetic subtypes and showed that um, even in patients with translocation 11-14 daratumumab, so because it was DARA cyborg, the DARA cyborg package was associated with similar types of response rates, but it makes me believe it's the DARA part of things. But that's one setting in which on cyborg you may not have an optimal response, but those patients with 11-14 actually have a good response to alkylator, so another reason to take them to transplant.
So my second question is that if a patient, like most of our AL amyloidosis patients are elderly with multiple comorbidities and multiple organs involved, especially the heart with cardiac dysfunction, and most of these patients, you tend to put them on either antiplatelets or anticoagulants.
Mhm.
So in general, like what is your approach for the anticoagulant and antiplatelet therapy for AL amyloidosis patients? Is it different from what you do for multiple myeloma patients? And if it is different, like you routinely practice doing a bleeding diathesis workup, like assessing factor 10 assay, because you know that these patients are at high risk of bleeding tendencies, especially the GI bleeds, especially if they have GI
Mhm.
amyloidosis, in addition to amyloidosis in other places. Do you routinely do endoscopies and colonoscopies before you start them on antiplatelet, anticoagulant therapy to document that the patients don't have GI amyloidosis?
No, in my practice, I don't do routine screening endoscopies, but I do look for factor 10. Our new patient panel for a newly diagnosed amyloid includes the factor 10 activity level. But when you look, we did a single center analysis, how many patients, because we screen everyone for factor 10, how common is it? It's actually very uncommon. Only about less than 10% of patients have a low factor 10 activity. And of those, it's less than 1% that will actually have clinically meaningful low factor 10. Many of these patients have like less than, it'll be 40 to 50%, but they don't have bleeding because of that. So I think that the screening, especially if you're working in the setting of, it's hard to obtain the test, it costs money, patients cannot afford it. I don't, it's a hard reach to screen everyone for a factor 10, but you could do a INR, and that can be a test to screen for these patients. And maybe in patients who have an elevated INR, think of it, unless they're already on warfarin. But I think the other part of, do you put people on antiplatelet, anticoagulant, I think that becomes a discussion with your other specialists. What is their cardiac risk profile? Do they have atrial fibrillation? We generally don't start on image, so I don't worry as much of the additional thrombotic risk. But in the setting of nephrotic syndrome, these patients are inherently, they have like a mix of a bleeding and a clotting phenotype. And so you have to, I think, personalize it for a given patient. But I don't generally use it just as a prophylactic. I will do it because a given patient's risk is too high.
Thank you.
Thank you, Doctor. Dr. Natraj, you had a question?
Yes, sir. Thank you for your wonderful presentation. Madam, I had two cases which I wanted to discuss with you. I had one young patient, about 45-year-old male, who presented to me with basically a heart failure. Basically, he presented to cardiologist, and then they assessed there was no coronary anomalies. So they did an MR. MR was suggestive of amyloid. So we got a cardiac endomyocardial biopsy, and in India we did IHC based one. IHC came back as SAA positive. So, but that patient did not, he was not doing well, and then his bone marrow, everything was normal. So then, because his son was living in US, so they went to UPenn, and in UPenn they did a repeat endomyocardial biopsy, and that was sent to US Center Mayo, and then it came back as lambda light chain restriction in the lambda light chain deposition on mask. So how common do you see this kind of discordant picture with IHC and mass spec? That is number one. And is it that we do for every patient whom we have a doubt that we run mass spec for everybody? Because the treatment will entirely change.
Yeah, that is exactly why my talks focus so much on getting that mass spec, because unfortunately when you have enough of these patients, I think most of the time you're okay, but for every like 10 cases you will make a mistake with just IH, like without the mass spec. And particularly in patients, the ones that I discussed earlier, they are older, they are men, they have a cardiac involvement, the risk of ATTR with coexistent MGUS is high. So those are settings where in even more relevant. But yeah, unfortunately, it's not common, but it is not that rare that you can disregard it in practice. But it's kind of sad that this patient had AL, but you didn't find anything on clonal workup. Because if the patient had lambda light chains, you would have thought of it more likely. But this is the part where amyloidosis is so heterogeneous. There are some, the disease just doesn't read our textbooks, and you have these kind of bizarre presentations.
No,
But
madam,
that's where,
I
yeah.
think
Go ahead.
discordant between IHC and mass spec, is it?
Yeah, that's where the IHC, who is doing it, how comfortable they are with with the antigens they are looking at. That is where that people have tried to look at concordance between this, and it again depends on the center, the pathologist who's looking at it. But that's where the mass spec now becomes a new gold standard, because here you're basically just reading all the different proteins, peptide bits that you can see in that Congo red positive tissue. The way the mass spec is done, you're basically doing something called as tryptase digestion of the Congo material, and then tandem mass spec of that digested material, and reading what all proteins are there. So what that gives you is a good picture, not just of the predominant protein, which becomes then the protein leading to the deposition. It also tells you all these other chaperone proteins and what else is there. So that's where I think um, it's hard for me. I don't, because I don't use IHC anymore in my practice. I don't know. I've not run into situations where I've seen this discordance, but this is where that gold standard in the last 2 decades has changed to mass spec.
Madam, I have second question. This is a second case. He is about 50-year-old young male diagnosed with cardiac amyloidosis. Lambda light chain is there in the blood, and then he received Dara VCD, and then he has done very well with respect to his clonal. Means FLC has normalized, bone marrow doesn't show any plasma cells, urine protein is not there, but his cardiac output still remains at 35%. So I want to do transplant, but it becomes sometimes very hard because PRM will become very high. So, and if I do transplant for him, should I do it at MEL 140 or should I reduce even MEL or should I do it MEL 200? And what would be, and
Yeah.
should I sort of give him, how do you manage hydration during during the transplant?
Yeah. And what
Practice
are
tips
the
for
cardiac
him.
biomarkers of this patient?
But still NT-proBNP is high, about 5,000.
Okay. So
Organ
this
response is
patient,
not good.
yeah, this patient, unfortunately, I would be very nervous to take to stem cell transplant because the risk is too high of transplant related mortality. The other is, I think this is another scenario where, we have assumed it is AL, but could this patient have some kind of hereditary amyloidosis or something like that? It's unlikely, but that's the other scenario why he's not getting better. And the third is that, this is a very, if the patient had a EF of 35%, it was very advanced cardiac amyloidosis. So has the heart gone to that point of no return? And in this setting, you're thinking of the other transplant, which is whether having a heart transplant is a possibility. Again, these are very, very selected situations. Lot of center experience is needed. I've not done a heart transplant in any of my patients, but there are centers in the US that will consider these types of situations where you have achieved a complete hematologic response, but the heart is not getting better. You try to get a new heart.
Okay. So you would not do autograft?
I would not.
Yes. I know I have also not done, madam. Last 6 months he's following up, but he's got different opinion from different centers. So that's why I thought I'd ask.
Yeah. No, that makes sense. Young patient, but these are the patients that in that IFM study from 2008, the high transplant-related mortality that was seen in the transplant arm was in patients like this who had very advanced, heart involvement. They don't, transplants actually just too risky, stem cell transplant, that is.
Thank you so much for the answers, madam. Thank you so much.
Yeah.
Thank you, Dr. Natraj. I'll take one or two questions from the audience. Dr. Krishnathan, just be ready with your question. In the meanwhile, I'll take some questions from the audience. Dr. Jyoti Bajaj Soni wants to know, does bone marrow amyloidosis regress or disappear after treatment?
No, it doesn't. If you biopsy the organ again, you'll find it. So I don't generally rebiopsy because I don't see this regression.
Okay, thank you. Thank you, ma'am. Another question from Dr. Nikhil. In a case of AL amyloidosis with massive hepatomegaly and intermittent bouts of severe abdominal pain, there is no other significant organ involvement. Your choice of upfront therapy, your choice of management of abdominal symptoms, and your role of auto transplant in this scenario.
So assuming that this is truly AL amyloidosis, and the patient has the full, picture of elevated light chains and good biomarkers, I think this is a patient you would try to take to an upfront stem cell transplant if the patient is otherwise eligible. If there's a delay, I think starting with induction, again, assuming this is systemic AL amyloidosis. Now the supportive care, unfortunately, is more challenging. I think I don't know what the bouts of pain are. Is this pain from hepatic like stretching? Or something else going on? Does the patient also have a splenomegaly and that's causing some problems? Or is this a situation where the patient has GI amyloid and is having intermittent ischemic gut? So I think that we have to, I'll need to have a little more information to figure out. But that supportive care sometimes can be very challenging. You sometimes have to admit these patients, figure out what exactly is the cause, and then appropriately treat.
And your role of auto stem cell transplant in this scenario?
I would consider transplant if the patient is otherwise transplant eligible.
Thank you. Another question from Dr. Mahesh. Any role of doxycycline? The repeat question. Role of doxycycline reducing already deposited amyloid?
Not anymore.
Thank you. Sir, your question, please. Dr. Krishnathan Kannan, sir.
Again, transplant related question, just as a take home message, I want to know from you, who are exactly the transplant eligible patients apart from the age, or what makes
Yeah.
them transplant ineligible?
So my really simple tests that I use are the two biomarkers, NT-proBNP more than 5,000, troponin T more than 0.06. I will not offer a transplant. Age, I think my oldest patient I've taken was 79, but I know like it's very center dependent, what upper age you use. And then there's also severe autonomic neuropathy. So if patients have severe orthostatic hypotension, even stem cell collection can be risky in these patients. Sometimes I use that stem cell collection almost like a little stress test. Patients who have horrible toxicity during collection, bad idea to take them to stem cell transplant. So I will use, but I start from the biomarkers, and go from there.
And if there is a renal impairment, what's your cutoff? I mean, for melphalan dosage, is it 140 versus 200?
Yeah, in patients who are on dialysis or EGFR less than 30 is where I do standard MEL reduction. Now, in myeloma, I have done MEL 200 even in patients on dialysis, but it tends to be a lot more toxicity, mucosal toxicity. So I think that, and again, I think we have started questioning the role of transplants with upfront data. So in someone who has renal impairment and we have to reduce the melphalan dose, I would question, like, is there ability to use daratumumab in these patients, because dara is renally safe. So it's kind of this new paradigm we have hit in amyloid, where we are questioning, even as transplanters, the role of transplant for this disease.
Yeah, thank you. Thank you very much.
Thank you, sir. Another question from Dr. Chand. What precautions to be taken to prevent veno-occlusive disease in autologous stem cell transplant in amyloidosis?
I don't have any specific guidelines for this. I don't think of VOD as a disease unique to amyloid. There are very small, occasional rare cases where VOD happens with high dose melphalan. I don't know if that is different in India. Like, have you seen more VOD? Like in my practice, I've never seen it in myeloma or amyloid patients, but I'm curious to hear from you all.
I have not seen in my practice.
Okay.
Another question from Dr. Sanjukta Rao. She wants to know, how do you monitor patients with cardiac amyloidosis in the absence of free light chain excess in blood, considering organ response, which lags behind the hematological response?
Yeah, here I would use the cardiac biomarkers, specifically NT-proBNP. You can do other things like 6-minute walk test is also there, but NT-proBNP is my go-to.
Perfect. Another question is from Dr. Sumit Mirk again. Similar to oligoclonal bands, which happens post stem cell transplant in myeloma, can transient elevations of light chains happen again in post auto transplants in amyloid also?
Yeah, I've seen that. Yeah, all the time.
Another question from Dr. Singh Win. How would you suggest treatment for hepatosplenic amyloidosis without other organ involvement?
So I would start with knowing what subtype it is, and go from there.
Okay. So another last question from Dr. Biswa Prakash. In the case of isolated hepatic involvement with clonal plasma cells, what would be your first line of treatment, and how would you evaluate your response assessment with only hepatic involvement?
Yeah. So if patient has clonal plasma cells and makes free light chain, then in that setting, that would be like, you have two things you have to follow: the free light chains, and assuming this patient has elevated alk-phos or enlarged liver, those are the other two things you can follow for organ response. In terms of treatment, if it is a AL amyloidosis process, then treating with chemotherapy with or without stem cell transplant would be how I would approach it.
Thank you. Dr. Mahesh, do you have another question? You raised your hand, that's why. So Yeah, Dr. Mahesh. So any discussion want to ask any question to Dr. Anita D'Souza? So
So can I ask you a question, Amit? Like, so if you have a patient that you want to do mass spec in, like what would the process entail, or is that just not, is there any place in India where that is currently offered or done?
right now, to my idea, I think there is no place in India
Wow, okay.
doing mass spec. Actually, I want to hear from you. So can we send sample to you?
Yes, yes. But unfortunately, we don't have the test either in our center. We send it to Mayo. But I think that is where, that's the challenge, right? If at the starting point itself, you have a disadvantage, and so you have to how do you go from there? And that there was a case where the patient then had another biopsy, or the tissue was sent and it turned out to be AL. I think that's a challenge. But I recently read that there's a new amyloid center that started in Kerala, and I was excited to see that there is a focused multidisciplinary amyloid center, but curious as to whether they do mass spec, but it sounds like maybe not.
To my knowledge, I think nobody's doing it. If anybody knows any
Okay.
center doing, I don't know. Any discussions,
Okay.
has any comment or advice regarding this? To my knowledge, it's not there.
Okay. Okay.
So anybody else, any question for Dr. Anita? For wonderful discussion. So I finished all the questions from the audience, and if no other questions from the discussions, well, thank you so much, ma'am, for that wonderful talk, fabulous talk, awesome talk, and what a question association. It was fantastic.
Thank you. I'm just
You
so
answered
impressed
so
with
many
the
questions.
engagement.
You're totally, for 1 hour, you're answering so many questions so patiently. And what a discussion. Wonderful. Thank you so much for being with us today on this Saturday evening for us and morning for you. Once again,
Thank you. I really appreciate the invitation, and I really want to thank all of you and the audience for very thoughtful and really very good questions. So I really appreciate it. Thank you.
And what you said in the beginning, that amyloidosis is a difficult disease today. Yeah, it is easy disease to treat. That is a take-home message now. Thank you so much, ma'am, for being with us. It was an honor for us to have you on board today at this Saturday evening for us, ma'am.
Thank you.
Thanks a
Good
lot.
night.
Wonderful. I now hand over to Mr. Prashant Agarwal for final vote of thanks.
Thank you, sir. Thank you very much. First and foremost, I express our deepest gratitude to our esteemed speakers, Dr. Amit, Dr. Amit also, Dr. Anita also, and I express my gratitude to the panelists as well. A special thank to Dr. M.B. Agarwal sir, who is conducting such a wonderful webinars, and he's making us the part of this such webinars. So thank you all of you, and good night to all of you.
Thank you, Mr. Prashant. Thank you, Anita ma'am. Thank you all the discussions over here, and thank you all the audience for spending your time this Saturday. Tomorrow, don't forget at 11:30 a.m. with another beautiful webinar. Thanks a lot. Bye.
Bye.